Exploration of the chest is a very difficult art, and this is because it requires the detection of sounds that are often at the threshold of audibility and jam-packed in very little time interval. Although this applies more to cardiac than to pulmonary sounds, it still makes our task very difficult. What we'll do today is to provide you with an algorithmic approach, but still keep in mind that what you really need is pattern recognition, which is the ability to recognize a sound as soon as you hear it. That requires practice, practice, and practice. Let's listen to respiratory event number 4. Now that's a quick one. In fact, there are no extra sounds in this cycle, and the underlying breath sound is very low-pitched, muffled, and has the last 2/3 of exhalation absent, and no silent pause between inspiration and exhalation. These are all characteristics of a normal vesicular breath sound, so this is just a normal cycle. Respiratory event number 1. Okay, when you're confronted with a respiratory event such as the one we just played, the first question you should ask yourself is whether there is any extra sound present in the cycle. In other words, you should ask yourself whether you hear any adventitious lung sound. In the event we just heard, there are no adventitious lung sounds. Thus, your task is limited to the identification of the underlying breath sound. Now, to simplify the topic of breath sounds, we can say that in a large sense, all breath sounds are really tubular breath sounds. And this is because they are all very much generated by air that flows in a hollow tube. It is therefore very important that you familiarize yourself with the characteristics of a tubular breath sound. Now, you can do that very easily if you place your stethoscope over your neck and you listen to your own tracheal sounds, the sounds generated by air flowing through the trachea. This is because tracheal sounds are classic tubular breath sounds. They have 3 major characteristics. The first one is that they are high-pitched, and because of their high frequency, they're well perceived by the human ear. The second characteristic is that they are long in exhalation. Their expiratory phase is as long as the inspiratory phase. And finally, there is a little brief silent pause between inspiration and expiration. Now, the problem with tubular sounds starts immediately after these tubes enter the chest, and they narrow into bronchi. Now, when they get into the chest, they become surrounded by a mantle of alveolar air, and this air acts very much like a muffler. So it dampens the intensity of the tubular sounds and transforms them into something that is entirely different. To be more precise, alveolar air acts as both an equalizer, very much like the one you have at home in your stereo equipment, and a low-pass filter. So it selectively eliminates high frequencies and keeps only the low-frequency components that tend to be soft and muffled. Sounds that come out of the bronchi, surrounded by this mantle of alveolar air, will be very different from the sounds originated by a simple tube such as the trachea. These new sounds, these chest sounds coming from the bronchi, will have 3 characteristics again. They'll be low frequency and therefore soft. They will be short in exhalation, much shorter than in inspiration. And this is because most of the high frequency components tend to be concentrated in the last 2/3 of exhalation. Therefore, alveolar air eliminates them entirely. And finally, the third characteristic is that there is absence of the silent pause between inspiration and expiration. Now, these muffled, low-pitched breath sounds are normally called vesicular breath sounds. Why vesicular? Very simple. Laennec himself, the inventor of the stethoscope, called them vesicular. In fact, he believed that they were generated by the vesicles, the alveoli. This is not true, because the sounds are still produced in tubes, in this case the bronchi, but are indeed filtered and greatly modified in their physical characteristics by the air-filled alveoli. Therefore, there are only 2 breath sounds you really need to be familiar with: the tubular breath sounds and the vesicular breath sounds. Okay, so let's go back to the breath sound of this particular case 1, and let's analyze the 3 physical characteristics which define a sound as being either tubular or vesicular. Let's listen to it again. Now, what you notice is that this sound is loud, has a long exhalation phase, which is at least as long as inspiration, and has a little silent pause between inspiration and expiration. So it has all the 3 characteristics of a tubular breath sound, and that's what it is. Now, tubular breath sounds, however, are normal only if they are heard over the neck. if they're heard over the chest, as in this case, they should be considered always pathologic. And this is simple. A normal chest contains enough alveolar air that is supposed to alter the physical characteristics of a tubular breath sound and transform it into a vesicular breath sound. So if you hear tubular breath sounds over the chest, that means that the alveolar air in the underlying lung tissue is gone and has been replaced by something that is capable of transmitting high frequency better. And high frequency sounds can be transmitted better by either a solid or a liquid. So what are the solids in this case? Well, the most common situation is the emptying of the alveolar air due to a collapse of the alveoli. Now, the airways are still open, otherwise you would hear no sounds. And finally, the liquids that can replace the alveolar air are very much either pus, and the patient has pneumonia, or blood, and the patient has pulmonary hemorrhage, or serum, as in a case of pulmonary edema. So the presence of a tubular breath sound in the chest, that we normally call a bronchial breath sound because the tubes that produce it are indeed the bronchi, indicates consolidation, either caused by alveolar collapse or by alveolar fluid filling. Now the question for you is, can you identify at the bedside the mechanism responsible for the production of bronchial breath sounds? So let's hear again our sound and see whether these bronchial breath sounds are due to alveolar fluid or alveolar collapse. Let's hear it again. Now, this can be done easily if you remember that the presence of fluid in the alveoli is often associated with the presence of fluid in the interstitium, and that fluid in the interstitium, in turn, is associated with the production of adventitious lung sounds, crackles. Therefore, a tubular breath sound which is not associated with crackles will be much more likely to come from alveolar collapse with open airways. And conversely, a tubular breath sound that is associated with crackles will be much more likely the result of alveolar fluid filling, still with open airways. Now, the most common cause of an alveolar collapse is usually a pleural effusion, and this is indeed what our patient had. Pleural effusion, which only occupies half of the hemithorax, will present with normal vesicular breath sound at the top, and this is because there is normal aeration in those areas, a tubular or bronchial breath sound in the middle lung fields, where the alveoli are collapsed but the airways are still open, and finally, respiratory silence at the bottom, where both airways and alveoli are totally collapsed. Now, the presence of tubular breath sounds may also help us out when we're dealing with the possibility of an endobronchial obstruction, and may even avoid an unnecessary bronchoscopy. Imagine, for example, a patient that comes in with a presumptive diagnosis of post-obstructive pneumonia, has a radiologic density on chest X-ray, but has tubular breath sounds on physical exam. It's very unlikely that this patient will indeed have a post-obstructive pneumonia. And this is because tubular breath sounds mean opening of the airways. The airways must be patent. Patency can be easily confirmed on chest CT by the presence of air-filled bronchi that are cast against a surrounding parenchyma that is consolidated, and that is called air bronchograms. Respiratory event number 2. Let's start by identifying the underlying breath sound. Is this vesicular or is this bronchial? Well, it's soft, it's low-pitched, and the last 2/3 of exhalation are absent, so this is indeed a vesicular breath sound. In addition, there are late inspiratory extra sounds. So how do we call these sounds? Well, it depends on your background. If you are from the US, you probably would call them crackles, or actually rals. Now, make sure you don't call them rails, because rals is French, and that's the pronunciation. If you are from England, you probably are likely to call them crepitations. And actually, the terminology over the years has become so confusing that in 1977 was standardized, and I think it's useful for us to review it a little bit. Now, all the problems started with Laennec himself. Now, remember, Laennec was French, so what he had to do was to use a French expression to define these sounds, and he called them rals. Rals is French for rattle. Now, of course, there were rals and rals, so he had described them by using daily examples that were as weird as Laennec himself. So some rals, he described them as the whistling of little birds. Other ones, he described them as crackling of salt on a heated dish. Other ones were like the cooing of a wood pigeon. Now, the terminology didn't start very well with these kind of examples, but it got even worse when Laennec realized that at the bedside he couldn't even use the word râle, because he reminded his patients of the French expression le râle de la mort, the death rattle. Now, that is the horrible noise that people that are about to die make when they can't clear secretions anymore. And of course, didn't make his patients very happy. So Laennec realized that to avoid trouble, he needed to come out with a different expression. And at the bedside, he used the Latin equivalent of rhoncos. Now, that was not clearly understood by his translator, John Forbes. And when his book eventually got translated into English, the terminology became very confusing. And it grew so confusing that in 1977, a standardization was required. As a result of that, the term râle was abandoned, and crackle became its official substitute. So we should call these sounds crackles. Now, crackles are very valuable sounds. Clinically, they are very important. And they are very important because they provide a diagnosis, if you recognize them and if you time them. Now, remember, sounds of this type are so short, less than 250 milliseconds, that they have been called discontinuous, which means that they are indeed less than 250 milliseconds. This term does not refer to the length across the respiratory cycle. Crackles are therefore so short that they can't really have any musical characteristic. They are noises, but they are valuable noises because if you can time them, you can identify the underlying disease process. Crackles are primarily inspiratory, although they can have expiratory components, but they are primarily inspiratory. And therefore, they may occur early in inspiration, in mid-inspiration, or in late inspiration. If they occur early in inspiration, they are generated by air flowing through large central bronchi. And these bronchi are covered with thin secretions, and it's this air-fluid interface and the bubbling generated by it that will lead to the production of these early inspiratory crackles. They are usually called coarse, they're low-pitched, and they're typical of bronchitis. They often clear with coughing. On the other hand, the late inspiratory crackles are generated by a different mechanism. They don't come from proximal large airways, but they come from peripheral distal airways, small bronchioli, partially collapsed by a high interstitial pressure. Therefore, there will be two pressures at the end of these bronchioli, a high central pressure and a low distal pressure. When the patient breathes in, all of a sudden he re-expands the partially collapsed bronchioli, and that creates a sudden equalization of pressures and a pop. And it's that pop that is the crackle. So late inspiratory crackles resemble very much Velcro. They are fine, they're loud, and they're high-pitched. Now, why is there high pressure in the interstitium in late inspiratory crackles? Two major mechanisms. It's either scarring of the interstitium, pulmonary fibrosis, or there is fluid in the interstitium. And this fluid can be blood or pus or serum, as we saw before. Therefore, late inspiratory crackles are sound of either pulmonary fibrosis or pneumonia, pulmonary hemorrhage, and a lot of pulmonary edema. Now, what about mid-inspiratory crackles? Mid-inspiratory crackles are neither as low-pitched as the early inspiratory crackles, nor as high-pitched or fine as the late inspiratory crackles. They're kind of in between, and they originate in inflamed and partially dilated medium-sized bronchi. So their diagnosis is bronchiectasis. They are typical of this condition, as was described by Nath and Capel in a 1977 thorax study. Now let's go back to our sound and listen to it again. Now, what is the timing of these sounds? These sounds are late in inspiration. They are fine and high-pitched. The late inspiratory timing may be difficult to identify since the underlying breath sounds is so soft that it's not too easy to identify its onset. But indeed, if they are late inspiratory, what is the mechanism? Are they due to fibrosis or are they due to fluid in the interstitium? Let's hear them again. Now, the answer is fibrosis. In fact, if the patient had had interstitial fluid, that fluid would have been very likely to spill into the alveoli, and the presence of alveolar fluid would have caused a bronchial breath sound. Now, this patient did not have a bronchial breath sound, had a vesicular breath sound, and that's why the diagnosis of fibrosis as a result of these late inspiratory crackles was more likely. Now, in order to approach and understand the presence of late inspiratory crackles, I would like you to refer to the algorithm which is included in your booklet. Based on the characteristics of the underlying breath sound and based on the presence or absence of late inspiratory crackles, you'll be able to sort out the underlying etiology. This is a little bit of an oversimplification, but it's very helpful when you are interpreting breath sounds and late inspiratory crackles, and therefore we will use it for the remainder of the workshop. Now let's move on to sound number 6, which is probably one of the most important sounds you can detect at the bedside. What you hear in this case is a series of short, explosive extra sounds that are superimposed on an underlying vesicular breath sound. They are present both in inspiration and in expiration, and they resemble very much a series of crackles, but they are not crackles. So what are they? These are sounds that are present both in inspiration and in exhalation, and therefore the identification relies on their quality, which is grating, creaky, and rubbing. They don't represent crackles, but they represent a plural friction rub. So rubs are not crackles for 4 reasons. The first one is that they are present both in inspiration and in exhalation, and that's the most important of the 4. Yes, there are rubs present only in inspiration, and there are rubs present only in exhalation, but most of the times they are both in inspiratory and in expiratory phase. Number 2, rubs are usually localized over the chest. Crackles tend to be bilateral. And number 3, crackles tend to be non-palpable, and rubs are palpable. Finally, rubs do not clear with coughing, and crackles tend to clear with coughing. Again, the most important reason for differentiating rubs from crackles is the symmetry, both in inspiration and in expiration, of a rub. Okay, now let us listen to respiratory event number 3. Now, this is a very impressive acoustic event. What's the underlying breath sound? Is it vesicular or is it bronchial? The answer is that it's vesicular, but it's a little bit higher pitched than a regular vesicular breath sound, and yet not high pitched enough to qualify as a bronchial breath sound, as a tubular breath sound. So that's the first point, and it's very important. By the time you develop bronchospasm, the first thing that happens is that your breath sounds become a little bit higher pitched. Do you hear any extra sounds? Yes, there are extra sounds, and they are in exhalation. Are they long or short? They're long. Are they high-pitched or low-pitched? They're high-pitched. So these are high-pitched expiratory sounds longer than 250 milliseconds, and they have a musical quality. And these sounds are familiarly known as wheezes. Wheezes are extra sounds whose reputation is probably a bit overrated. In fact, they are clinically valuable, but they are often confusing. They may even mislead us. And the reason for that is that wheezes would be tremendously useful if they could be produced like the tone of an organ pipe. In an organ, each pipe generates a tone that is the result of the diameter and the length of the pipe. If wheezes could be produced in this way, we literally would be able to analyze the physical characteristics of the sound and through a mathematical formula reason out the diameter of the originating airway. Now, this is unfortunately not the case because airways are not organ pipes. They are shorter than what would be necessary to produce wheezes through this mechanism. So wheezes are not produced like the tones of an organ pipe, but they are actually produced like the sounds of a little toy trumpet, where a reed made of 2 sheets of metal starts fluttering as soon as air flows through. Now, in an asthmatic patient, the sound generation is based on the Bernoulli principle. So you will have air rapidly flowing through narrowed airways, and this will create a sucking effect on the airway walls. The airways will start fluttering, and this will create the wheeze. So the Bernoulli principle that operates in this situation is very much like the Bernoulli principle of your vacuum pumps in the lab, where rapid flow of water through a hole in a tube will suck air from the outside inward. So in summary, it's not really the diameter of the airway, but the flow of air through the airway, which is responsible for the production of wheezes. And that's why there are some very interesting phenomena that you need to be familiar. An asthmatic that is about to stop breathing because of respiratory failure and fatigue may not be able to wheeze anymore because it's too tired to move enough air. And that's the conventional dictum of beware of a silent asthmatic. Things may not be getting better, they may just getting worse. Conversely, a normal subject may paradoxically generate such a forced expiratory flow to produce a wheeze. And that's why forced exhalation at the bedside is not a useful maneuver. It does not unmask subclinical wheezing, may actually misdiagnose asthma in normal patients. In other words, wheezing is neither sensitive nor specific for asthma. In fact, it was shown as early as 1977 that wheezing may resolve quite rapidly after treatment with bronchodilators, even if the patient's airways remain 50% of normal. And finally, remember also that wheezing carries a very wide differential diagnosis. In fact, not all that wheezes is asthma. It is essential, for example, that you recognize stridor. Stridor is a high-pitched, wheeze-like inspiratory event. It's different from a wheeze because it's always in inspiration. Wheezes, on the other hand, are either in expiration and in inspiration, or only in expiration. They're never inspiratory only. So it's important that you pay attention to the timing of these sounds. Finally, keep in mind that even an expiratory wheeze could be originating in the upper airways. The mechanism would be an adduction of the vocal cords. So the reality is that you can't be sure unless you put your stethoscope over the neck, and if the wheeze is louder over the neck than over the chest, then the site of origin is most likely the upper airways. There is another form of wheezing that you need to keep in mind, and it is wheezing in the presence of heart failure, and that's called cardiac asthma. So again, wheezes are valuable clinical signs, but they lack sensitivity and specificity, and they are unable to pinpoint the site of the tracheobronchial tree that is responsible for their generation. So they are not as clinically valuable as crackles. One last point. If you're trying to assess the severity of an asthmatic, do not rely on the presence of wheezing, but on their length. So an asthmatic that wheezes only in exhalation is not as severe as an asthmatic that wheezes in exhalation and in inspiration. Respiratory event number 5. Do you hear an adventitious lung sound in this cycle? There is indeed an extra sound, and it's low-pitched, it's snoring in quality, and it's superimposed on a vesicular breath sound. Now, this extra sound is early in expiration and is long enough to qualify as a continuous adventitious lung sound because it's longer than 250 milliseconds. So based on recommended terminology, we would call it a continuous low-pitched adventitious lung sound, and more commonly we refer to it as a rhoncus. So this is a rhoncus. Now, rhonchi are usually very difficult to identify because they vary a lot. Not all rhonchi are created equal, and yet they share a common mechanism with wheezes. They are caused by air flowing through a narrowed airway. For rhonchi, the narrowing is caused by inspissated secretions. So rhonchi tend to be very often present in obstructive lung disease, where they are scattered. Now, they have a snoring quality, but they may vary in timbre and characteristics. Now, in contrast to wheezes, rhonchi are coarser, lower-pitched, and often localized, and if they persistently remain localized, then you should be concerned. In fact, a persistent localized rhoncus, or even a wheeze, may be the only clue for an underlying occult neoplasm. And in this case, even a normal chest X-ray should not defer bronchoscopy. And this was exactly what this patient had, an occult, small, endobronchial obstructing tumor.